to start with the first question, which is a question concerning definition, actually. How do you actually define governance? And actually, do you mean governance mainly at the healthcare service level, or at the regional level, the national level, or at the international level? And so maybe Suraya, Dalil would like to start.
Yes, indeed. Thank you, Florian. Thank you for this opportunity, and it's an honor to be in this panel today. Governance is not about control and not about rule. It's about institutions. It's about policies, processes, practice, as well as laws and regulation that ensures setting the vision, directing actors reaching towards that vision, as well as putting oversight mechanisms and accountabilities in reaching toward the vision. So in other terms, governance means that in health sector, it means that leveraging the potential of all actors and achieving health and well-being. And with all actors, I mean public actors and also actors beyond the public. Public actors include government and parliament, but also beyond the public actors includes communities, civil society, private sector, private for-profit, and private not for profit. So that is, in a nutshell, the definition of governance. Governance is also about, in this definition, governance includes responsibility, governance includes transparency, governance includes accountability for results. So these are the values, the ingredients of governance. With regards to health, it's far beyond Ministry of Health, because it's about also determinants of health. It's the structural forces that drives inequalities, social norms, gender norms, and eventually drive ill health. So when it comes to governance and health, it's absolutely beyond the health sector itself. It's about food system, it's about education, it's about water and sanitation, it's about security and safety, it's about trade and so on. So it's a very much the multi-sectoral and sectoral aspect of it. And it's at the national level, but also at the sub-national and local level in any given context, but also in terms of the national governance vis-a-vis global governance and the regional governance and all of that. They're all well connected with each other and they reinforce each other.
Thank you a lot for your great response. And I would like to address the same question to Jan, please.
Thank you very much. Of course, there's not much to add after this wonderful first approach, but let me give two perspectives. I think there is a kind of legality perspective in governance, and that's, of course, the rules of the political system to solve conflicts between actors and adopt decisions. That's the legal aspect, but there is also the legitimacy. And then governance means the proper functioning of institutions and their acceptance by the public. And I think acceptance by the public is a key feature of our governance efforts. So we can make excellent plans if it is not embedded and accepted by the population. And I just have to refer to, for instance, the COVID-19 vaccination campaign. We have really seen how important the acceptance by the public is. Of course, we very often use not only governance in general, but also the term clinical governance. And I think that's also an important one in healthcare. And that clinical governance, of course, is a whole system through which we organizations are accountable for continuously improving the quality of their services and safeguarding the high standards of care by creating an environment in which clinical excellence will flourish. And I think that's important because it also refers to important concepts, as Suraya said, accountability, but also creating the environment in which excellence will flourish. And I think that both components, the general definition of governance and then looking at the clinical governance, are extremely important when it comes to building strong and accountable healthcare systems. And of course, governance should always be related to an aim. And I think the quintuple aim nowadays helps us to define clearly what are the aims of a health system that wants to focus on universal health coverage, and that wants also to put an emphasis on primary care. And of course, the quintuple aims, we know them all: improving the care as experienced by the individual, improving, of course, the health status of the population. And then in the older days, people said the third one is cost reduction. I don't think that you can take that seriously nowadays. If you look at the demographical evolution in the forthcoming decades, most of the countries will spend more on healthcare according to population and demographical evolution. So we reframed that in our country as realizing more value with the resources available. And I think that's much more a positive kind of framing than cost reduction, realizing more value. And this value, of course, we include technical value and personal value, and also equitable distribution of resources across all the patient groups. But not to forget also the fourth dimension, the societal value, the contribution of the healthcare to social participation and connectedness. And I think that's extremely important. If we see how disconnected and fragmented today our societies are, primary care especially has to play a role in strengthening social participation and connectedness. And I think that's an important component of where our health system and our governance should contribute to. Of course, we have the fourth aim, creating added value for the professionals, informal and formal caregivers. And the fifth aim, extremely important, I think, is working towards social justice and inclusion. And I think that those two dimensions recently have become more and more important. And I think that especially primary care is absolutely able to contribute to this inclusion, to this social justice. And I think, for instance, if I look today at the way we are dealing with some certain problems, I saw still this morning the launch of a kind of new program on reducing inequalities in cancer patients. Now, I think that's, of course, a noble kind of aim, but I think it's a dangerous one, because if we are going to make distinctions between different patient groups according to their disease, and then have special programs, for instance, on equity for the cancer patients, I think that's the wrong way. We have to focus on all people with all conditions. And we know from our experience in low and middle income countries, how devastating a healthcare system is when it is focused on vertical disease-oriented programs, because we very often see that those vertical programs, they are destructive for the development of primary care, of generalism. And I think this is a very important discussion nowadays, because when we go into the pathway of inequity by disease, so that means two persons with the same physical and functional condition, but with different diagnosis, have other access to the healthcare system and other access to diagnosis and to therapeutic interventions. I think that's the inequity that us, the healthcare system ourselves, that we create. And I think it's a very serious concern. For us, there should be no difference. And I think so, if it comes to governance, we have to make sure that we don't fall into the problem of creating more and more inequity by disease. And I think that that's absolutely a challenge also for the governments. And then, of course, there are the four levels. We have to put governance at the nano level, the interaction between the provider and the patient, the micro level, the local group of caregivers around the people, around patients, interprofessionally working together. The meso level, in our country, we defined the meso level at 100,000 people. That's a kind of group of people that are geographically in the same area and where organizations work together in order to enable the micro level to be efficient and to be strong. And we just 2 years ago, we started to organize our country in 60 meso levels of more or less 100,000 people. And this works very well. It started on the 1st of July 2020. And it's amazing to see how all the stakeholders, being the local authorities, the health and care providers, the social sector people, and then the patient representatives and the informal caregivers, that they work together at the meso level in order to organize the conditions that enable people at the micro level in the daily care for patients to absolutely perform very strongly. And then, of course, the macro level at the national level, financing, structuring, all kinds of licensing to practice and so on. I think that's very important as well. And we should not forget, I think, the international macro level. I'm pretty much convinced that for the future of Europe, it is key that we can contribute to a new dialogue with Africa in order to create opportunities in Africa for a development of strong primary care and strong other levels of care. If we don't do that, I think we will be in trouble in the forthcoming decades. And I think that's a very important challenge as well. So I would like to stop here and to set the scene in that way.
Thank you a lot, Jan, for this really, really interesting and educative answer. And I would like to ask Bob now about your perspective.
Well, thank you, Florian. I think Jan and Suraya have said it quite well. The only thing I would add is that I think governance is most obvious when it's missing. And it is missing a lot in primary care. I know the United States is not unique in that regard, but we lack governance so completely that our national pandemic plan only mentioned primary care once as a footnote. And so it's quite reasonable to understand why primary care was left out of our response to the pandemic. And I think we have to make a decision. Are we going to put in place a role that someone wakes up every morning worried about primary health care in the United States? Because currently there is no such role. And if we continue to let it be governed by the marketplace, and increasingly by what we're calling the 5th C of primary care, corporatization, Walmart and Amazon will be the main governors of primary health care in the United States in the next decade. Thank you.
Yeah, thank you for this response as well, of course. And then I would like to continue with the second question for our panel. And how do actually effective governance, how can it actually really help to improve the quality of primary healthcare or to achieve universal health coverage? And do you maybe have also an illustrative example in your mind?
I want to start with the fact that we have seen that health systems should not only be concerned with the health outcomes, which is improved health, improved indicators, but also about values. And those values are equity, human rights, communities engagement, and social justice, in order to achieve equitable outcomes. And I think what governance does is that, yes, we move towards the outcomes. These are our goals, but also those values are embedded, enshrined in the health policies, in the plans, in the strategies, and in the direction that the health sector is taking. And I think that's a very important design decision, because the way you design and orient the healthcare system is very much influencing the outcome, especially with regards to equity issues. So this is one. Second, I want to say about why this is important in primary healthcare. Primary healthcare, first, in terms of the definition, it's not only about primary care. It's not only about the first level of services, the first point of contact of the health system with the population. It's also about the determinants of health. It's also looking into social, economical, political, and environmental, and also lately the commercial determinants of health. So in primary healthcare approach, health is addressed in its totality, and people, communities are looked at not only when they are sick, but also when they are healthy, bringing the prevention and the promotion and the protection aspect of it. And that's why the governance for PHC-oriented health system is the call of our time, because we need to look at issues related to trust in health system, trust in health services, social justice, social inclusion, about also people not only recipient of healthcare, but also having a voice in the healthcare itself in terms of demand for accountabilities, demand for better health and more health, demand for more fiscal allocations for healthcare. So it's part of the co-creation of health together with the population themselves. And that's why the legitimacy and the legal aspect of the governance is becoming so important, because that acceptance by the people is key in this one, in order for them to function in an adequate manner. I also want to say that we have seen, for example, in the child mortality reduction, that almost half of the reduction in child mortality from 1990 to 2010 happened because of the fact that other sectors did very well, especially in terms of GDP per capita, economic growth, education, water and sanitation, and gender equality. So those were enhancing factors for reduction of child mortality. And that's why when we say, okay, health and well-being and health for all, then the governance aspect of that, especially governance for primary healthcare oriented health systems, is becoming a key factor, because health system is also about the design, how you design your health system, how you design the models of care, how the referral and counter-referral works, how the human resources development and distribution is working. So these are all levers interplay with each other in order to make sure that the system is designed on primary healthcare principles, values, and foundation. And talking of primary healthcare and the levers, I want to say that WHO and UNICEF have developed an operational framework for primary healthcare. It outlines 14 levers. 4 are strategic levers and 10 are operational levers. One of the strategic levers is governance and policy frameworks. So it's a standalone lever within the PHC operational framework. However, we know that it influences other levers within the operational framework. For example, it influences financial allocation. It influences community participation and engagement. It influences quality of care and so on. Yeah, that's it from my side for now.
Thank you very much for this excellent response again.
Again, Suraya offered such a complete message. I think I'll keep it succinct to reiterate a few of the key things she said. In the United States, when we released our National Academies report on implementing high quality primary care in 2021, we came as close as we could to saying universal healthcare by calling it a common good. It should be like roads and schools. Everyone should have access to it if they want it. We offered a definition that wasn't completely new, but it took primary care, foundational care, into the realm of primary healthcare and describing what it should be able to achieve and who it should be able to address. And we created a blueprint for what needed to change in policy in particular, but in practice also, to achieve that. What I'm so pleased with is that our Assistant Secretary for Health took it to another level. She recognized that we needed to go from primary care to primary health care, which is a huge move for the United States, and recognizing that it is bigger than primary care, but we have to solve the problems of primary care while we do this. And one of the strategies that we've used to help kind of galvanize all of our agencies in our Department of Health and Human Services is to stop talking about primary care and primary health care as the goal, but to Suraya's point, what does it have to enable? So our Milbank Quarterly article and the way we've structured our conference in July is around what are the most pressing national health problems that need to be solved, and what is the role of primary health care in achieving them, and why are we losing ground in the United States, with life expectancy going down for the first time in our recorded history? What do we need to do to enable primary healthcare to achieve that? So it's trying to lift the gaze. What does it need to achieve? And then getting specific about who needs to work together to make sure that it addresses equity, mental health, and opioid epidemic, pandemic recovery. And that's what seems to be energizing folks around this thing called primary healthcare, and in thinking about how we give people access to it, even if politically we're unwilling to go as far as universal healthcare. Thank you.
Thank you a lot, Bob. And now, please, Jan.
Well, I want to go now to the nano level. Maybe it's a little bit strange, but I think it's essential. Because if you ask people, how was the healthcare that you received, what will be their answer? The nurse answered my question. The doctor listened to me. The person on the desk understood why I did not find the right way to find the department that I needed. So it's all at the nano level that we create the value that's perceived as by the patient as making a difference in a positive sense. And at the nano level, I think we have a huge challenge. Most of our care, also at the primary care level today, operates from a disease-oriented approach. We look at diseases and try to implement evidence-based guidelines in order to improve the situation of the patient. But I think we need, and clinical governance will play an important role, we need a paradigm shift from a disease orientation towards an orientation that looks at the life goals of the patient. The question is no more what's the matter with Mrs. Johnson, but what matters to Mrs. Johnson. What makes Mrs. Johnson's life worth to be lived? And especially when it comes to multimorbidity, that will be more and more the rule, certainly in countries like mine, where in the next 2 decades, we will have the most important group of people over 80 and over 85 that we will ever have in the history of our population. So that's really a challenge that we are facing. The sense of urgency is not yet there with in the policies, but it should come there. And if we don't have the paradigm shift towards looking at the life goals of the patients, I think we will get stuck. We will get stuck in guidelines that are contradictory. We will get stuck in limits to our capabilities of maximize all the diagnosis and making a maximal technical approach. So that means that we have to engage in a new dialogue with people where we focus on their life goals. We have to put their life goals central in our electronic health record, because that will influence the way we are going to work with them. And life goals, yeah, we know that they change over time, that they change when the context of the patient changes. So our health system should be prepared, and our caregivers should be prepared to go the way with and to walk the way with the patient during the journey in his life. And this is not only for our multimorbidity age population, but also for all the people. I think that starting from life goals makes our care relevant. And that will ask a lot of governance at the micro level and at the meso level. Nowadays, already thousands of primary care providers, nurses, family doctors, occupational therapists, physiotherapists are trained in a goal-oriented care approach, so that you focus on the life goals. And I think that's a very important effort that we make, and that's preparing the future of dealing with a population where multimorbidity will be the rule and no more the exception that it was 40 years ago when I was a student and a professor presented a person with 3 morbidities and said this is exceptional. Today, it's, I think, a very important shift that this has become the rule. So let's focus on that. And at the same time, not forget that we are in a global context. If we see the challenge of this pyramid that will widen and widen the top of the demographic pyramid, we have to think, how are we going to organize infrastructure in society? Where are those people going to live? And we have to think that this will be only for 20 or 30 years, because this kind of demographic situation will never come back. There will be no baby boom no more. Here is a person that's a product of the baby boom. We have 6 children at home, as many others, but that will never come back. So we have to think about infrastructure that can cope with these problems of the people that are actually there, the very old people, and at the same time think about the future and see that we prepare also a healthcare system that will have to cope with a completely different demographic structure. And I think that's absolutely a challenge when it comes to governance, that we are not looking to the next elections, not to the elections after that, but that we are looking to the next generations and prepare already how society will be ready. I'm not sure. I hope the politics and politicians will be able to take that perspective, but I think it will absolutely be a challenge. And for me, that's one of the things that we should look at. When we talk about governance, we have to focus on the different levels, the nano level, the micro level, the meso level, but also at a broader macro perspective and translate that into policies that will be intersectoral, that will not only have to focus on health and healthcare, but we have to focus on infrastructure, on education, on housing, on labor, and so on. And I think that's the challenge we are facing now.
Thank you a lot, Jan, as well. And now I would like to continue with the next question concerning international differences. How do primary healthcare governance models actually differ among different countries? Do you maybe have some role models in your mind, or is there something you would like to wish to be seen implemented in your own country? So, which are some remarkable differences among different countries which you might have in mind? Please, Suraya.
Thank you, Florin. These are very good questions. Before answering that one, I just want to add on the previous point with regards to comorbidities, with regards to not looking into the next election cycle, but the needs of the next generations and so on. And I think within that also, we need to bring other realities of our generation and future generations, including climate change, including population movement and population displacement, and so on. And I want to say that in developing countries, in addition to the comorbidities, the increased life expectancy associated with comorbidities, non-communicable diseases, etc., we still have to tackle with the maternal mortality, with child mortality, with infectious diseases, with communicable diseases, and so on. So the burden or the work for developing countries is much more than only looking at the comorbidities due to the demographic shifts. So this is one. Now, with regards to examples, I would rather answer this question with regards to what are the factors that influence governance models in the countries. And those factors to me are institutional arrangements. For example, how actors are involved in the policies and in laws, about decentralization in the country, about public-private sector mix, the prominence of private sector, about capacities, about resources, and also about the culture and values in each country. So these are the factors that defines the governance models in the country. In addition to that is, of course, the geography, the geopolitics of countries, and those and the political economies are factors that affect the governance.
Thank you very much. And
so I'll start by saying one of the things that concerns me, but also gives me some faith, is that one of the commonalities that I'm seeing right now is that primary care and primary health care are struggling in many countries. Whether you look at the National Health Service or you look at Australia, I mean, there are countries that we looked to for more ideal primary healthcare systems that are struggling to figure out what they're going to do next. So I think the challenge is broad, and we have an opportunity to learn from each other and to make some shared agreements and to take on some shared experiments. I'll say that in my travels around the world, the systems that I have experienced that I would love to be cared for in include in the Netherlands, where I think, to Jan's point, is they're building new communities to take care of the next generation's aging issues. They're embedding primary health care right in the hub of it, and they're surrounding it with social services and physical therapy. They're surrounding it with all of the things that you would want to be able to walk your patient to get that next set of services. And it was just such a brilliant arrangement and very purposeful in design. I also enjoyed visiting the Pegasus system in Christchurch in New Zealand, which of course had to rebuild from its earthquakes. But in doing so, the hospital decided not to rebuild one of the wings of its hospital because the primary healthcare system had done so well that their inpatient services had been significantly reduced. And I just was stunned at the purposefulness and the resilience that it created in the community after a major disaster, that people really had their trusted relationships there. It really emphasized continuity. It had after-hours care that respected continuity, but also respected, to Jan's mentioning of the fourth aim, the workforce, the clinicians. So where I've seen it well is usually in pockets. I struggle to point at any single government and say that they've got it right, but we're certainly hoping to learn from some of them in July.
thank you a lot, Bob. Jan, please.
Yes, if I may add to that, I would look first at the global perspective. And I am absolutely in agreement with what Suraya said. We have to make a global effort. And for instance, our university, Ghent University, has created now an international thematic network, Climate Health, which is looking at the nexus between climate change, migration, and health. And we did some focus groups in Africa. And it's absolutely clear that with local family medicine doctors, they experience this interaction continuously. For instance, even today we were in contact with one of our people in the Prima Famet network working in Malawi, where recently there has been floods, there has been a lot of challenges. And of course, this leads to negative health outcomes and also to big problems for the health system to cope with that. So we really have to look at the ecological aspect because that's essential for the future, that we deal with that continuously. At the same time, I think we have to have an open mind to learn from each other. And for instance, we learned a lot from the African experiences with community health workers. Very often there is a group in society hard to reach, but if you see how community health workers, for instance, in practices like in Chaiwelo in Johannesburg in South Africa, where they really look at the population, they are living with and within the population, they look at health indicators, they look at social indicators, and they try to make a community diagnosis and putting into practice community-oriented primary care. This is absolutely an inspiring model for us to also look at our population and to see how we can make sure that everybody counts and no one is left behind. And I think that's very inspiring that we can learn from each other in that sense. Also, when it comes to mental health, I think the community-oriented approaches and improving the mental health conditions, we all know that there is no evidence that the greener the environment you live in, the less problems with mental health will be in the population present. So we have to look really in a comprehensive way and learn from each other, see what are the good models. Also, when it comes to financing, we have been in the opportunity in Belgium to install a system of integrated needs-adjusted capitation, where you have a lump sum according to the needs of your population, where you pay your nurses, assistant nurses, family doctors, physiotherapists, and so on, with an integrated payment. Well, this is an excellent preparation to realize integrated care. When you want to make care more integrated, the integration of the payment system is important. That's the one thing. And the other thing is, of course, the integrated electronic health record is also important, where also the patient is actively participating in the collecting of the information. And we have to learn from each other so that we can better try to understand what works and what doesn't work. Although there are differences, as Suraya has described, that are in payment system and historical components, but yeah, make the historical determinants an opportunity and not necessarily a kind of blocking mechanism to make change happen. I'm always amazed about the degree of person-centeredness when I assist to doctor-patient encounters in Africa. They really look at the patient in the complete context of that person. And I think that's very inspiring for us, because we are sometimes too much and too restrictive looking at people. So let's have an open mind to learn from each other. Let's invest in exchanging our experiences, and at the same time, let us look at the global picture, because that's an important challenge to deal with.
Thank you a lot, Jan, for this great response as well. And now I would like to ask the audience if somebody from the audience might have a question to the panelists. Yes, I'm not sure who was first. I think it was Luke. So please, Luke Ellen.
I think it was Amanda, actually. Amanda, you go first, and then I'll jump in.
Amanda, yes. Okay. Please, Amanda. And welcome.
Seriously, thank you, Luke. That's very sweet. Age before beauty, my father used to say. So thank you, colleagues, very much for a really, really interesting discussion. I mean, huge. And one thing that I want to recognize is that many of the colleagues who've spoken have been working in this field for a long time. And one of the things that we see is you're constantly having the same discussion, which measures, for which reasons, data against personal experience, against systems management. And I really respect colleagues for their resilience and continuing effort on behalf of populations more than just their own. So that's wonderful. Now, the question I wanted to ask was right at the beginning. Dr. Suraya said, I don't mean by governance something negative, and then gave us a really inspiring set of definitions. But I think in many countries, governance has become restrictive. It's a lowest common denominator. It's about safety. It's about how money is spent. And I think that it is really difficult, even at the macro level, to persuade governments and senior managers to invest in a way that has stability beyond political elections or in the face of adversity. And often governance actually becomes about how are you spending the money? And that's the bottom denominator. And many of the things that you've said, colleagues, are what I would call our values that drive us to have bigger discussions about what matter to people. But I wonder, the bottom line is, how do we persuade people who don't necessarily share those values that the experience of the patient and equity across the community and an effective primary healthcare system that meets the needs of the people, how do we persuade them that those things really count to the financial model as well as the rest? Because that's the thing that I found in my lifetime has sometimes defeated me. I think I know why I need to do things and why government should invest, but they don't always agree. Thank you.
Thank you for the fantastic comment and the great question. Maybe one or two of you would like to answer. I'm not sure.
Thanks so much for that, Amanda, and for giving such a nice reframe to Soraya's great comments too. I think it often comes down to purpose and accountability. I think our governance, at least in the United States, I'll speak for us, tends to forget what healthcare is supposed to achieve and what the purpose of the healthcare system is. So that in my own state in Virginia, only 2.5% of Medicaid total spend is in primary care, but we take care of most of our children on Medicaid. We've seen a decline in how much of our resources we put into primary care to the point that we're starving it. And that's failed governance, or at least it's not governance aiming to achieve a population outcome. And the most recent effort in my own health system is that one of the measures that they're looking to put in place for primary care is number of new patients per month. So they've basically declared that we are just a triage function for high cost services in the healthcare system, and not actually aiming to have relationships, not aiming to use those relationships to improve health and health outcomes. And it is fairly normal. So I think we have to have a reconfiguration of not just governance, but intention, because I think that's what will drive the governance in the right way. And if the purpose of our government is likely to, like as you said, to put in the guardrails, not always negative, but it says you can't go outside of these boundaries, then we need to put up the right guardrails around primary care, how it's financed, how it's measured, how it's not just financed, but resourced to achieve those outcomes. And that's where we're driving government right now.
Yeah. I want to add on that, and Gandhi said that politics should be sacred. And with that, it means that politics should be on an ethical ground. It shouldn't be on profit or for profit or for personal benefits. It should be on a high moral ground. And I think that is what we need to hold account our elected officials, that the politics should be based on the ethical foundations. So this is what I want to bring into the discussion. Back to you, Florian.
Thank you very much. Then there will be
I'll keep it quick, just to follow on from what Suraya said about elected officials. I've got a very thorny question for each of the panelists, which is around the role of community representation and participation, which is a core part of governance. But many countries around the world, it plays no role whatsoever. particularly in more autocratic regimes, it can be quite difficult because there's a tension between democratic values of representation and participation versus maybe a more hierarchical reality in politics. What's the role of your external organizations in speaking into those countries, specifically where you've not been invited to offer an opinion? And the background to that, I guess, is the rise of the multipolar world we're living in and reduced tolerance of countries to have other external players meddling in their internal affairs. It's definitely becoming harder to set normative standards. But that's what WHO and lots of us are in the business of. We want strong primary care everywhere. How is that relationship changing?
If I may,
Please.
and thanks for the question. It's a very challenging question, but it's obvious. Alma-Ata was born after the May 68 movement that analyzed in a critical way society and that put the values of participation, democracy, and so on high on the political agenda. And Alma-Ata has been influenced by that debate. Hence, even today, and the situation is not easy in many countries when it comes to all kinds of things that you mentioned, Luke. But I think that primary care, because we are in touch with the people, we hear the way they live, they value developments in society, what they appreciate, what makes their lives worth to be lived. I think we are at the front line of that debate. And that means that in the way that we address ourselves towards the community, we have to look that it is open to diversity and that it really represents the values that are important. There are limitations, certainly in certain countries, to the extent to which, as a healthcare provider, you can also put that into the societal debate. But at least I think in our practice, we can see that we are inclusive, that we are focusing on social justice, that we cherish equity in the way we approach our patients and our communities. And of course, by the information that we collect, we can also give a kind of societal diagnosis about what's happening in society. And that can be related to, for instance, the way people have the possibility or not to express themselves. And I say that all very carefully because I know the complexity in many countries, but I think inherently primary care is an emancipatory process anyway. It has been that from the very beginning, and today it's still that. And I'm also the director of our WHO Collaborating Center on Family Medicine, Primary Healthcare, and we focus very much on those values and making them also clear in the practice of the way we organize. I've been working for 40 years in a community health center where we take care of 95 different nationalities. Well, you are there, you have no other choice than being inclusive, than being open to diversity, because that's the only way that we can do that. And sometimes it's challenging because 40 years ago, it was a complete white waiting room. Today, it is as diverse as possible. So in 4 decades, people have to make that transition. And what I learned from our personal experience is it is so important that we as healthcare provider, modestly, but clearly also contribute to the debate about this kind of changes and challenges, also with the politicians. Sometimes when people ask me, what did you do? What difference did you make in your community? Probably at the individual level, at certain moments in time, you mean a lot as a family physician, as a nurse, as a primary care worker, for the people that you take care of, for the families and so on. It's about life and death, it's about important things. But modestly, I think the most important thing that I could contribute to, we have put this community, that was the poorest community 40 years ago of the city of Ghent, on the political agenda. With the other actors in the local community, and we have put that on the agenda, and we have asked attention to look at the way these people had to live and to create opportunities also for them, and I think that's our finally also one of our tasks, and we know that primary care is helpful in creating connectedness and social cohesion. Well, let's invest in that aspect as well, because politicians know that without social cohesion and without connectedness, it is impossible to build any societal project.
Thank you a lot, Jan, for this response.
Yeah, thanks, Florian, and great to hear this discussion. I just wanted to come back to this point around alignment of governance for primary healthcare, and in many parts of the world, the focus on national health policies, strategies, and plans. And Suraya has clearly articulated that governance for PHC is the call of our time. Many parts of the world will need to think through how governance for PHC aligns with and really drives the overall national health policy and strategy. And particularly given Suraya's deep experience in this, I'd love to hear a little bit more about where the PHC governance might fit within the overall national health policy strategies and plans. And secondly, in relationship to that is how those relationships, those human interactions that often drive policy change, how we can catalyze that or support that. And it would be great to hear Jan and Suraya's perspectives on that. Florian, thanks.
Yeah, I think this is a very good question, and I go back to the PHC principles and values as it has been defined in the Declaration of Almata, which is equity, human rights, social justice, and communities participation. And I think if the governance is based on those values, then those values will be the force to, or the guiding principles for policies, whether those policies are about healthcare, education, built environment, distribution of resources and wealth, etc., etc. So I think the bottom line for me is those primary healthcare principles that were really agreed by all member states during the Cold War era, but it's as relevant today as it was in the last century. So I think we have to go back to those fundamentals and start with those fundamentals. Thank you.
Thank you a lot, Suraya. Yeah, and I think Jan, you wanted to be...
Well, very, very shortly, I want just to add to the excellent analysis Suraya made, that there is a dimension that I'm more and more confronted with also with my experience as a trainer of family medicine and now of interprofessional teams, that is the tension between generalism and specialism. And I see really a challenge today to motivate people for generalism. The whole construction of a lot of our undergraduate training is focused on specialization and subspecialization. Of course, this leaves out the broader context of what Suraya has so well described and the principles. I see that sometimes it's so difficult to recruit nurses, family physicians, and so on for primary care, because they look at the safety of a specialty. That means you narrow the domain you're working in and you're focusing on a well-defined problem. Whilst generalism, it's open. A patient comes with tiredness, it can be any kind of problem. So it's much more uncertain, it's much more challenging. You have to learn to live with uncertainty. And for me, that also this tension between generalism and specialty is a very important one that as a society we will have to deal with. And of course, we learned from COVID that it's so important to invest more in generalist providers at the primary care level, but also at other levels, because that's the people that you need when you have to address new challenges like a pandemic. And so for me, that's one of the fundamental problems. How are we going to change that mindset and to find people that are motivated to take the risk to become a generalist, because it's so safe to specialize and subspecialize. And today you have to make it sure for career-wise, and when it comes to research, those that do best are those that know almost everything about almost nothing. And I think that that is one of the fundamental problems in our society. How can we recreate this kind of enthusiasm for dealing with broader, with general, with transversal thinking? And I think it's absolutely a fundamental question nowadays.
Thank you a lot, Jan, for your great response. And we have one final question from Pia, my neighbor from Slovenia.
Thank you, Florian, and hello to everyone. So actually, Shams took my question off my tongue, but I would still like to reemphasize this really important thing, because to implement PHC approach effectively, it's not enough to have health systems governance oriented towards strengthening primary healthcare, but we also need primary healthcare governance. And countries all across the world are seriously lacking institutional capacities at national and at regional levels, also at local levels, for primary healthcare governance. And this is especially important because of this characteristic of primary healthcare, that it's really fragmented. And all this fragmentation, and now also introducing multidisciplinarity, they seriously lack leadership and governance. So I think all countries, we need to strengthen our capacities in health systems science, focused on primary healthcare, and ensure also primary healthcare units at ministries of health and also at regional governance. Over.
Thank you a lot. I'm not sure if Jan would like to respond, or...
I'm very happy with this comment. I think it's important, and it really takes time, because the first thing is you have to make aware your politicians that it's not sufficient to organize your hospitals, but that also primary care needs structure, needs organization, needs a definition, needs a regional and territorial circumscription, and also installing a mechanism of accountability. And that takes time. We took 10 years before we could establish our primary care zones in our country that define 100,000 people as the target group that you organize your meso level, your organizational level on. We are now on our way to look at the micro level. If we cannot establish a kind of primary care networks, that means 4 or 5 practices that are accountable together for 10,000 people and have to organize the daily care. But we are forced to do that because today we have, for instance, patient stops. There are 20% of the practices, primary care practices do not accept new patients. So you have to organize a system that's able to put into practice the right to access to quality primary care. And so with their primary care networks that will have a duty to accept people that live in a certain region at the level of the network, I think we will try to establish that. And there is not much experience, and we have to study much more on this. And I also appreciate very much that you say, well, it's not only about management, it's mainly about leadership. I think leadership and management, it's important distinction. Management is about planning and budgeting, organizing, staffing, controlling, and problem solving. Whilst leadership is about designing the direction. It's about aligning people. It's about motivating and inspiring and energizing people. And we need leadership also. And we underestimate the importance of leadership in our training programs and so on. And with the WHO Collaborating Center at Ghent University, we emphasized a lot in preparing people for leadership from the very beginning of their undergraduate training, and doing that in an interprofessional context. For instance, we train them in going to a community and make a community diagnosis and then implement community-oriented primary care principles. Well, one of the things they learn by this experience is, amongst others, is the importance of leadership. So I could not agree more, and we have to really emphasize that. And I think that at all levels, WHO, universities, EU, international organizations, we need to perform better and to make more efforts in that field.